started, why don't you guys introduce yourselves? I'll start with Margaret.
Yeah. So good morning. I'm Margaret Haynes. I am the CEO for Right at Home and RiseMark, which is our holding company. So it's a pleasure to be here. Thank you.
Good morning, everyone. Dave Causby, CEO of Gentiva. I've been in the post-acute space for 30 years and almost all of it in home health and hospice.
Good morning. I'm Mary Baxter, and I'm the COO for Senior Helpers. Been there for 16 years, so a lot of changes over the last few years, hasn't there? So.
Yeah, and so just to kind of kick things off, just to kind of set up the stage, I think all of us can talk to some of the headwinds from a reimbursement perspective, but I guess, Margaret, let's start with you. Talk about what you're seeing at Right at Home, and then we'll go to see what's happening. Nothing too exciting, David, right?
Right.
It's just easy peasy, lemon squeezy over there in the home health side.
That's right.
Kick back and relax,
Yeah,
right?
kick back and relax.
To no surprise, we have a lot of headwinds that are facing us as an industry, but I always view headwinds as opportunities. And when I think about what we're seeing across the Right at Home network, so I was just sharing with some of the teammates up here, we have over 700 locations globally, and in the U.S. we're about 530 some locations. And we just got done celebrating. We're actually going to have a big celebration on Thursday of hitting our highest weekly hours as a U.S. brand that we've ever hit. And that's, this last week we did 453,000 hours of care in a single week. And so to us, that's what we look at versus maybe the revenue numbers and whatnot, because that means we're touching lives in a very meaningful way, something that I know all of us in this room are really, really passionate about. But when I look at some of the trends that are happening in our industry, so from an hours per client perspective or hours per caregiver, we have seen a decline in that coming out of the pandemic, but actually where we sit now is where we were pre-pandemic. So we see about 24 hours a week per client, and we see about, this is average, and then 26 hours per week per caregiver. Certainly associated with that, the trends we're seeing as well, as we all know, bill rates have gone up, and that's a result of also pay rates going up. So just in the last year, we saw bill rates increase about 6%, and pay rates increase about 5.5%. So there's really kind of staying in lockstep. But what I find interesting, and the thing that we're always thinking about, is we want to make sure that we as a home care industry or healthcare in general, and all of us here, we want to be able to take care of as many people as possible. And with those bill rates getting higher, does that shrink the market that's actually able to afford our services? So we're starting to think about how can we do things differently, very dialed into what does that look like in terms of that bill rate, and how can we supplement some things, maybe from a technology or whatnot, and I think we'll get into some of that here in a little bit, that allows us to still take care of that vulnerable population. And it's also a matter of making sure that coming from the home care side, where our primary payer source is family funded, how can we partner with the home health side of things, or the hospice side of things, or the palliative side of things, so we collectively together can do what we are all hoping to accomplish, and that's help people age gracefully, right, wherever they call home. So we do see, from a payer mix perspective, again, across the Right at Home network, we are at about 76% family funded when I look across the entire network. The next highest payer source for us is the VA. And I think that ties into a lot of work that's been done over the last several years by the National Association, the Home Care Association of America, or HCIF, has been really pivotal in helping our industry elevate those reimbursement rates. But reimbursement rates coming from anything where the government is controlling it, that's scary, right? Because with a stroke of a pen, we can, all of a sudden, we're at the mercy of them. But I think there's things, again, that collectively we can continue to do to support that. So then our third highest would be the waiver business in states, and then other things like long-term care insurance. So I think payer source is something that as an industry we need to watch. This business model itself, and how do we continue to make it available to those who can benefit from all the services that we provide in across the healthcare ecosystem. And certainly the caregivers and the family caregivers that we need to continue to stay focused on because they are the bread and butter. Yeah.
Right. And you touched on government pay and stroke of a pen, and David's probably chomping at the bit to speak now.
Well, yeah, I think, as I sat here and thinking about, talking to everyone in the room about creativity and ideas and things to do differently, I think one of the things that I would challenge everybody in the industry to think about is there's a lot of noise and complaints about, the Medicare Advantage penetration, the rates associated with Medicare Advantage. And, I think as an industry, we're down at the bottom of the funnel when you look at patients that are being moved into our services. And we've taken a totally different approach recently. We're predominantly now a hospice company. We got acquired by Humana. They took the home health business and integrated it at Centerwell. We just did an acquisition back in November, and so I've got 18 home health offices. So we're moving back into the home health space. So we offer personal care services, hospice, and now home health. But thinking back on all of the complaints that are out there about reimbursement and continued rising costs, we really have kind of taken a different approach. We've now developed what we're calling an advanced illness model, which is more of a palliative care model, because we believe that there's a ton of patients that sit between home health being restorative and hospice. And that book of patients is probably some of the highest utilization of cost of patients across the country. And most of you probably realize there's not a very good palliative care model that's out there. The reimbursements, Part B billing, I don't know anybody that makes money at that business. And I think that we're doing a lot in Washington to try to show value and show how we could bend the cost curve of people that are falling within that category. But that's probably going to be years down the road before a reimbursement happens. But my point to that is we've went back to the payers, and we're partnering with physician group practices that are at risk, and we're also partnering with Medicare Advantage companies to offer a program of a PMPM to manage these patients on a risk-sharing basis and share on the upside and the downside. And also, even with our home health business, instead of accepting the rates that Medicare Advantages are putting out there, we've really tried to partner to go in, and I've seen incredible collaboration to where we're sitting down with these payers and trying to understand what their needs are, and then trying to come up with ways to solve for their needs and to show outcomes that bring the value back to our business. I just think the industry's got into, it's a necessity that these payers have to have, and they set rates and just expect you to take them. But if you can find a way to drive quality outcomes, if you can drive a way to go find the right people inside of these payer groups, understand what their needs and their issues are, what they're trying to solve for, other than trying to find the lowest cost provider to be able to take it, show the value outcomes that you can bring, we have found that we're actually getting much better contracts and rates now than we were historically. So I think just being a victim and just having to accept what you get in our industry is only going to lead us to have more frustration. There's got to be innovation, and there's got to be ways that we as an industry try to go and prove the true value of what we can do and use, a lot of analytics and outcomes to demonstrate that. And if we do that, then I think we'll have a much better opportunity in the future for being a value add and get recognition for that.
Right. No, that's great. I think as we think about reimbursement and ways to, I guess, streamline operations, one of the things that I see, and I think a lot of you guys see, is that people think they can just buy a technology and it solves the problem, but often they don't fully utilize, the functionality of the technology they invest in. And I think one of the things we can all do is kind of squeeze what we already have into working even better and more efficiently. And I think you had some ideas on that, right, Margaret?
Yeah, so that's so true that a lot of times there can be a lot of shiny things out there, and it's like, oh, we just need to move to that next thing. But we all know that anytime you have to move software, particularly around kind of your core operational software, it can be very disruptive. But there's times when it's the right thing to do to move to something that maybe has more functionality. But what we've certainly found across our network, and even me as a user, gosh, I've used Excel and Word and all those things for years and years, and I still can watch someone navigate when they're doing something, up on the screen, and I'm like, I did not know that there was that shortcut that you could do. And that's something that we've been really focusing on, is just around, as we think about the margin pressure, that gross margin pressure that's happening between the bill rates and the pay rates, that in order to still have a sustainable, profitable business, you need to think about how can you squeeze out some operational efficiency below the line. And so part of that is making sure that we are using technology systems, software, things that are going to allow us to do things more efficiently. And in many cases, it's not a brand new thing, but it's really breaking down what we're doing into the micro experiences or the workflows, and using the technology to actually make sure that that is an efficient process and gives us the outcomes. And what David talked about in terms of the data, that's something too that we as a home care based company are focusing a lot on, to say, even though we're all using the same technology, we may not be tracking everything the same across all those locations. And that's something we're really focused on, because we do believe that data is going to help us overall as a complete industry show the continued value of what we bring. And we play such a critical role in the healthcare ecosystem. And we need to help continue to educate, as much as I think the pandemic highlighted that, the value that we can bring. I think we've got such a long ways to go in terms of that. But so from a technology perspective, we're leaning into the functionality that exists with operating software and functionality that exists with applicant tracking systems, because we know it's really important with the caregivers being a scarcity resource out there. You want to be able to reach them right away when they express interest, and how can you use the software to match up to their availability and what you want to accomplish.
Right.
Yeah.
And what on your side, David? What are you guys doing to squeeze more efficiencies out?
Yeah, I mean, we're looking, at different software technology. We're actually now hiring some actuarials. We're starting to build algorithms ourselves to kind of look at, patients with high risk leading indicators that, we can track and identify, so that we're trying to prevent rehospitalizations and ER visits, and talked to a few vendors since I've been here, because I think that it's kind of the leading edge of where we need to go. I mean, I think, we've done over 30 transactions out there, and I'm amazed at when we do transactions, unfortunately, the lack of sophistication in these operations and the synergies that come out of it. And I just think that people have got to get back to the very basics of blocking and tackling, how to operate and run a home care agency to maximize the margins and to be able to then to reinvest it back into the business. And so I just encourage everyone to really just look at your operating structure to make sure your staffing models are appropriate. We just did a transaction, and it was a $650 million business that we did a transaction on, and we took that business and we looked inside the business and we overlaid it into our operating model, how we operate our businesses. And we're in the midst of taking 650 people out of the branches that were overstaffed to fit our model of how we run our footprint across the country, with better quality indicators, better patient satisfaction, lower turnover. And I just see these inefficiencies that are out there. And so I would just encourage people, first and foremost, get your operating structure in place. Make sure your staffing levels are appropriate. On the home health side, utilization of paraprofessionals. You can even do some of that on the hospice side to try to keep your costs down from a margin standpoint. And then once you get that infrastructure, then you really need to look at vendors that are out there that help you, whether it's on the coding side, whether it's on clinical documentation, whether it's on patient identifiers, whether it's on your employees and the databases and benefit plans. But I just think that the entire industry's got to raise up and use the basics, and then you have to pick and choose what areas inside your business that you're really seeing a deficit, and look at vendors. There's a lot of good vendors and technology out there that can come in, and not one size fits all. It's really just a matter of where you're seeing your individual needs and opportunities.
One thing I was curious about is like centralization. Is that how you're squeezing a lot of things out of?
Well, I mean, it is. I mean, we do a lot of centralized back office type work, but we have over 500 independent offices that operate out there. Each individual office stands on its own with a leader and the full staff and the clinical staff. But we've just kind of built a playbook across that a branch is a branch is a branch, and here's your staffing ratios, and here's how many people you need, and here's how many clinicians you need, and here's the triggers when you hire somebody else. And it's just, if you don't have a very rigid staffing model and the way you operate when you run that many, you just think about every branch. If you have half your branches that say, I really need one more person, well, I wake up one day with 250 more people than what I had the day before just because of a subjectivity feeling that said I needed that person. And so, this is a tough business. And with the reimbursement pressures that we have and the labor pressures that we have and the costs continuing to go up, I think operators have to be extremely efficient and look, but centralized back office things, some central intake type things, centralized on call after hours type things. So there are some of that, but it still just gets back to the fundamentals of each branch standing on its own 2 feet.
Right. And you're talking on the workforce, and I wanted to get Mary involved here and talk about the centers of excellence and how you guys are using that really as a differentiator, but also upskilling your caregivers. Mm-hmm. But it also impacts retention as well, right?
Right. I think right during the pandemic, we, like everybody, we had difficulty finding caregivers and looking across the system. It was our franchise system is we have to hire experienced caregivers. Have to. And I started looking around and go, how do you know how experienced they are? Do you go with them? Are you watching them? You're assuming they're coming in, sitting around a conference table, and you're talking to them. Don't do this, do that. You do a few reference checks. They tell you their background. You send them on the way, and it works for the most part. You get some caregivers will call you up and say, "Help! This client's too much for me," and it just realizing that the training wasn't where it needed to be, and we had an opportunity to bring in people who have always expressed a desire to be in the care business, but didn't have the experience. So I went across the country with my team. We looked at what our franchisees were doing in training. It was inadequate. It really was. It just wasn't, in my opinion, sitting around a conference table, it wasn't enough. So we started out we have 5 corporately owned stores, and we went all out. We built an actual 4-room apartment and said, we're going to train our caregivers. We're going to train them in the environment that they're working in. And we're going to watch them and see what they're actually doing in that environment. So we built these. We have a living room, a kitchen, full bathroom, and a bedroom. And we made each room a training center. And what we found in most cases, even with our corporate stores, is that those caregivers really weren't as trained as they said they were. Actually scary at some points. So we were able to upskill them, train them, give them a much bigger confidence. Now that Center of Excellence serves for 3 purposes for us. It's once we built it, we decided the model. We many times you launch things before you're ready. We didn't do this time. I'm really happy about that. We started slow. We did it 1 corporate store, then another corporate store, and then once we really came up with a great curriculum and a program, we did like in our family room, in our kitchen, we almost did like an escape room. We'd say to those caregivers, go in there and find 30 hazards quickly in 1 minute. And we just cluttered the kitchen and put old food, or, instead of on the wheelchair, we put a basket of clothes, which isn't functional, an ironing board with the cord sitting there. And, we'd made it very difficult and made it fun, we made it fun. Then we had wooden stairs and carpeted stairs. Show us what you can do with that client on wooden stairs and carpet stairs. And then in the bedroom, show us how you transfer. Change the sheets with the client on the bed. We really watched their skill sets, train them, and then once we perfected it, we started getting phone calls from caregivers. Is this the place that does the fun training? Like, yeah, that's it. Come on in. And our attrition dropped in our corporate stores. And we really saw that our caregivers were staying with us, because when they did get uncomfortable, we had a Hoyer lift in there, we had all the equipment, we could actually see that they felt more confident. They were staying with us longer. So then the next challenge really became, how do we get our franchisees to buy into, I don't want to add 1,000 square feet, and we didn't ask them to. We have a modified version. They can do a studio. They can use I think last night I was laughing, storage space. Some people actually use storage space and meet their caregivers there. But the Center of Excellence is purpose for threefold, right? We bring in our caregivers, we train them, we can even bring in nights for movie nights because it's hard being a caregiver. It's a thankless job, right? And they have nobody to talk to. We bring them together, they vent, sort of little therapy sessions, they have fun. So we found that we were using it for that and training purposes, and that worked. The second area we found is our families are deficient. Families aren't trained. You know, they get discharged from the hospital, take your family member home, you'll figure it out. How do I do a transfer? How do I give them a shower? They don't know how to do that. And you don't have caregivers there 24 hours. That's when the accidents happen. And that's when we lose our clients. So we thought, well, let's bring in our families. Let's train them. I'm giving you away all our great secrets here. And we brought in our families, and the families were, become loyal because they don't know how to do these things. And then, of course, you bring in your referral sources to show you what you're doing. And they were like, wow, this is great. So I thought we would get some pushback when we said to all of our franchisees 3 years ago, we want you to do this in every location. And by December of 2023, you need to have some sort of center of excellence. Probably of all the things we've ever launched, it was the most popular, well-received decision. They love it. Their attrition has dropped. They're able to recruit. They feel like they've got valued training and credibility. And it's probably one of the smarter decisions we've made in terms of caregiver management. We just don't feel like any system-wide that our caregiver problem of shortage of caregivers or untrained caregivers is near what it used to be. We feel really good about it.
Yeah, that's great. I mean, the geographically dispersed workforce is always a challenge, and I think you were talking about an engagement approach you're also taking.
Yeah, it is. With home care, obviously we're dispersing. They're not coming into an office to work at. They're going out to individual homes. So it can feel very lonely, and caregivers can feel very isolated in terms of not having support around them. So we're testing a couple different engagement platforms that allow the offices to efficiently kind of keep checking in with the caregivers in a unique way, in a fun way that they find, there's some gamification that is included so that caregiver has access to immediate resources in terms of things they could be doing with the client, things that they could learn or understand about maybe what a client is facing, or as the family member is there helping the family member understand, gosh, here's something that would help you if you went through this particular training to understand what's going on with mom or dad or the loved one. So that engagement is really important. And so I applaud what you're doing because at the end of the day, there isn't enough caregivers. That's always going to be a problem that we're going to face. It's a math problem, right? And so we've got to find other ways in which we can, with the great caregivers are out there, support them, give them great opportunities to grow in their profession, as well as then how do we fill in the gap with something else?
Yeah, I want to jump back to Mary because you're talking about the caregiver shortage and how do we stretch our caregivers even further. And your flex home model does a couple different things, but I feel like that's also an angle to get more out of a caregiver by touching more lives.
Right. So flex home really came about not so much because of the caregiver, although it works real well because you don't need as many caregivers. But our flex home model, I think you probably all know fractional care, staffing in a community, going in, doing 15-minute bath visits, et cetera. But at the point when the rates for billing rates went up so high, we also did an analysis of who are we serving, and we had a lot more VA clients. Our VA business grew a lot, and then we had some waiver, and we had a lot more long-term care insurance suddenly. But the area where people were dropping hours was in the middle. Our CEO Peter Ross likes to say there's the haves, the have-nots, and those in the middle. And those in the middle were cutting back their hours because it became so unaffordable. It's gotten very expensive. So how could we do a little better job for them? And what we found is they were reluctant to start care and using their resources until they desperately needed it. And we all know what that means. When they desperately need it, it's too late. So how could we get in there sooner? So we took basically the home care model and said, well, how could we go into not communities or facilities, but go into neighborhoods and do 15 minutes here and a half an hour here. Now you have to be patient. It takes a while to get to that break-even point. But we thought we'd start where it's obvious. We started in the villages in Florida, got a wrapped golf cart, and we went around and we started picking up clients doing this flex home model. What we were able to do also is just have less caregivers, right? Because one caregiver can take a whole neighborhood for a whole day. It just takes a while to build the program, but what we also we're getting from it, and we're doing quite well with it. It was slow, and it's not an easy process because your software systems have to work with you. That's not easy. You have to be patient. But we found that, of course, these clients, once they learn that, yes, at these billing rates that we're charging, they try you first at a smaller amount. They like what they see. They feel comfortable with the caregiver. They feel like hey, I do need more care, and they're moving from flex home to care. And that's really what the goal was. But they have to try it. They have to get comfortable and feel like they're spending their resources, their money appropriately, because it's becoming a little bit unattainable for some people, and that's that middle class.
Yeah, I think that hourly rate, I mean, in the home health side, it's not really, it's evolved much further. You're talking about per patient per month type reimbursement. What other types of things do you see?
Yeah, well, I think, organizations have to look at it differently. There has been, a demand on trying to find clinicians to work out in the markets. And I think one of the things that we really engage on was a lot of employee surveys and really trying to figure out what the needs of our associates are. One of the last things that we put in about a year and a half ago was one of the biggest complaints was on call and after hours. And, clinicians working Monday through Friday, 8 to 5, and then having to go out after hours and see patients and nights and weekends. So we ran a little pilot, and we heard that was kind of the biggest complaint, and found over a period of about 2 months, some pretty good outcomes that came from it. So we've hired 600 RNs to be on call nights and weekends. So if you're an employee and you come work for us, you work Monday through Friday, 8 to 5, you're never on call, never nights, never weekends. You say 600 employees, you do that at $80,000 a pop, it's $48 million is what it costs us to do it. I had to have a strong conviction that I was going to get the ROI on that. Historically in our business, turnover is around 40% because there's a lot of burnout. We're industry low right now at 25% clinical turnover. We're seeing star ratings go up. We're seeing employee satisfaction go up. We're seeing, clinical quality of going out and seeing patients and avoiding rehospitalizations. We're seeing admissions go up. We're able, when you're on work all day and you have an admission at night or on the weekend, you might find a reason not to admit that patient. But we saw a total transformation of the culture of our company. And that's just because we're listening, to what the needs of the associates are. And we're actually, for the first time ever, got more people coming in wanting to join the organization than ever. We have, in the last year and a half, not had any recruitment-related problems or issues. And that's because if you want to work in home care and somebody says you can work Monday through Friday, 8 to 5, you're never on call nights or weekends and get your holidays off, or you can go down the street and work for somebody else, even if somebody else is paying you $2,000 or $3,000 or $5,000 more. We've seen people leave because they think they want to go make more money, but then they turn around and come right back because their quality of life, their experience, being home with their families, providing care during the normal hours of work is a greater satisfaction outcome than even compensation. So I just think you have to look at what the needs are in your branches and what your issues are, and just don't say one size fits all, or if you come work for us, here's what it is. Because if not, you're going to be on the treadmill, just turning. It's just something that we have to pay attention to. It's just not one size fits all, and we constantly have to be evolving to find the needs. I always say those with clinicians, will win.
Right. Yeah. On the family pay side, any thoughts on breaking that hourly per person, rate? Anything?
Yeah, historically, obviously, the industry from a home care perspective is 1 hour of care for 1 hour of a caregiver's time. And I do think that we have to break that cycle just because of the sheer recognition that there aren't going to be enough caregivers to keep up with the demand of the services that are out there. And so we are looking at ways in which how can we supplement the caregiver. We don't believe that we will ever replace a caregiver in the home. Even if there are robots that can come in and do certain things, I can at least tell you from my own personal experience, I will not let a robot do certain things with me, and then I will need a caregiver to do certain things with me. But that's down the road, hopefully, and I won't need that too soon. But we are looking at technology, right? I think we have to find ways in which technology can come in alongside that caregiver, can come alongside that family and provide peace of mind and some additional oversight, connection, monitoring when the caregiver's not there. But also technology can be really helpful while the caregiver is there. And so we're in the process of testing some different combinations of technology with caregivers. We call it Right Assist. We're also testing a model around more of a concierge type approach where you have a bit more tenured caregiver that has a broader breadth in that local community that can really be what we call that easy button for that family. And so they can push the easy button, that concierge care contact would then be able to say, oh, okay, it's not just that you need care for your loved one, but the plumbing is not working, or a tree just fell down in the yard. So I can push the easy button, call that concierge care, and they can help disperse that those resources beyond just. And it allows an opportunity to really start building relationships with those families in advance of that moment when they actually need care. So thinking a lot about how do you just get in the home earlier and bringing value to what we are all going to go through called this aging process.
Right.
Yeah.
No, that's great. I mean, kind of shifting over to the collaboration side, I'm going to put Mary on the spot. I'm sorry. Mary, Margaret, and myself, we're in a franchise system, and it's really common to have private equity investors. But recently, senior helpers just went back into a private equity ownership. Before that, you were owned by a hospital system, and you said you had some really interesting experience there that you'd like to share when you think about what really goes on behind the doors.
Yeah, I think it was interesting. It was a strategic partnership that we thought, I think from both sides, this was going to be obviously such a great connection. You've got the 8th largest healthcare hospital system in the country, and they came to us and they bought us and said, okay, let's work together. And they had 75,000 providers in their system, and what we learned is they don't know anything about home care. I mean, they didn't know what to do with us at this point. I mean, they wanted to. There was this great idea to collaborate, but it's about a whole huge, I mean, when you're owned by such a large system, the compliance department is mind-boggling, right? So just to get your home care agreements approved and joint, collaboration of brochures with your names on it would take 6-8 months just from the compliance department, and then the legal department. And we weren't used to that. We were like, we got to take care of clients. We've got to get going. And the whole goal is we can lower your readmissions, and this is why they bought us, like to work together. They had their own home health, they had hospice, so they wanted to add home care. It was a great concept, I think, but what we found is we had to go in and learn collaboration meant education at the highest level. I think we all have found that getting into the hospital systems is get past that gatekeeper, getting everybody involved is really challenging, and they have their own referral systems, and we had meeting after meeting with discharge planners and the different department heads, and loved the idea, brought them to see the Center of Excellence, loved the concept, but implementation and getting that working relationship going was just about as challenging as it was if we weren't partners. But what we learned is they really at the highest level don't know what home care is. What's the purpose? They didn't understand that, yes, we're sending home our client with home health, or we're sending our client home with hospice. What do you guys do? And so there's just that education, constant education. So it was an experience. Now we're back with private equity, and it feels like a good thing.
But you guys have a very innovative, this life profile tool, right?
Right.
I thought that would really resonate with the hospital
They loved
system. But you still couldn't get them.
Well, we did get some, what I found, yes, we did get a couple different systems within their system to use the life profile. Our life profile is an actual where we have an app that measures what the probability will be if we go in and do an assessment tool with an app that shows probability of readmission, fall, stroke. It's a very comprehensive questionnaire. We used to do assessments where we'd sit down at the table, talk to the client, but this is much more quantitative, and they actually loved it. It's why they bought us. They actually bought us because of that. It wasn't about it's the segment that bought us loved everything that we do. It's just the system's much bigger when you get into like a hospital setting. It's just much bigger than one group of people that thought it would be a great idea.
Yeah, and I'm going to go over to David too. I mean, you guys run a more sophisticated model. We're still kind of like the mom and pop type business trying to figure it out. But yeah, talk to us about your experiences, and I'll ask it two ways. One, with you're talking to your MA plans, you're talking to the hospitals, but also between your side and kind of the non-medical home care and the opportunities there. It'd be really interesting for a lot of us to hear.
Yeah, I think that, as I said, you have to work on the payer side to find out what their needs are and try to get value-based agreements and at risk and to try to solve that piece of it. Yeah, I think that from a community standpoint, I think everybody probably has sales reps that are out in the community. They're calling, in our business, they're calling on ALFs and SNFs and hospitals and primary care docs. But I really don't see the collaboration in markets between providers. So if you're in a market and you run a home health business, or if you run a hospice, or you run a personal care business, we need to have better collaboration in the communities to where we have a trusting relationship, because you're just working in a silo. And unfortunately, these patients, if you think about what we just talked about, from the age 65 on, their continuum could go back and forth. They can need personal care services, they can need home health restorative, then they could go back and need personal care services, and then maybe they need palliative care, and then ultimately another home health episode, and then maybe palliative care, and then personal care, and then ultimately hospice. That's the journey of a patient. But many of us just work in a silo, and the only thing we do is what we can control. And so I just encourage people out in the markets and communities, lean on each other and have a relationship. And if a patient comes to us and, they're hospice eligible, we think we got a referral, we go out and we visit the patient, we don't turn around and if the patient's not eligible and go back to the doctor and say they're not eligible, good luck with it. We're trying to get partnerships with home health companies to say patient's not eligible for hospice, they could probably be restored, and really you could use some nursing and therapy services. And so when you get those in your local community, not only is it a great opportunity to have another healthcare professional, it's a leader to bounce ideas off of and go to lunch once a month and talk about what's happening, but you're really starting to become proactive about the patients that live within your community and trying to help them navigate the post-acute healthcare world and find ways to, where they're able to either restore themselves or need home care services or then ultimately end-of-life care.
Yeah. Yeah, I think that's what we're trying to crack the nut on is being that partner with home health, because home health traditionally is really just in the home, 2 or 3 times a week,
Right.
And trying to be that eyes and ears. But I think a lot of us struggle with breaking down the silos, really, and really partnering with the local providers in the community. I don't know if you have any experience at Right at Home.
Yeah, certainly that's symbiotic and synergistic relationship between kind of the home health, the entitlement program payer sources that they support with, an action that's happened or an event that's happened, versus someone that can come in and just holistically around what the family needs. We're looking at always building those, and it's a very local relationship. So from a national perspective, we're always looking to build relationships across home health, hospice, palliative, all of that. But it all comes down to a local level and dealing with the local operators in the communities. So we certainly, Medically Home, we're doing partnerships with them because there is such great value between the two. And it's not that we are competing against home health, nor do we feel like home health is competing against us, because it really is, there's a definite need and support that has to come from both pieces. We don't ever want to take care of a client from a family-funded perspective and not have them tap into if they can qualify for Medicare services, the VA services, other kinds of things that would give them something that they're entitled to take advantage of as being part of this great country, right? So we want to be able to make sure they're tapping in to the right resources, getting the support they need there. And I think about my own mom as she was going through Alzheimer's, and we had home health that came in and hospice that came in, and they did wonderful care of my mom, but we needed someone there when they weren't there to allow my dad to be the husband, right? And to allow me and my sisters to be the daughters. And so that symbiotic relationship worked really, really well to allow my mom to pass at home and to be surrounded by her loved ones. And it was the hospice that helped us understand the dying process, and it was home care that came along the side that actually brought us some of the spiritual side of it all. So I just think that there's so much opportunity. And I think as I've been in the industry now for 13 years, and when I think about the ebb and flow, you see some big home health getting into, okay, they want to do personal care, family funded care as well. They'll buy into that or buy a system, and then they later will maybe sell that off and push it off and say, hey, we just need to focus on home health. And I think that's a natural ebb and flow. But I think it's indicative of the fact that they really are two different business models. Our focuses are different, but all in a really good way, and both have a really important role to play. And so even now with the guide programs that are coming out, we're looking to partner with companies that can be the partners in the guide program around supporting people with dementia, and how we can be an arm to them to help provide that respite care and those home assessments that are needed as part of the guide program. So I think we've got a ton of opportunity to continue to collaborate. I think also at the broader association level. So, being lucky enough to serve on the HCAOA board, it's great to see the relationships, and just over this lobby day that we had back in April, for those that participated, being there with Knock on the Hill as well. And that just really, I think as we can continue to collaborate holistically in our space, good things will come.
Yeah, because I feel like sometimes we whine a lot. I guess we're in Napa, we're allowed to whine. But how do we get credibility? How do we get credibility? Mara, do you have any ideas on how we can continue to build our credibility in the home care space?
Yeah, we've had this conversation the last several years as the rates have gone up. We have to have credibility. We have to change what we're doing. We have to, we're looking at skilled care. We're looking at how qualified are our franchisees to do what they're doing and charge the rates that they're charging. And that's why we came up with Life Profile as a mandatory. It's mandatory that every franchisee in our system uses the Life Profile program, which looks at really gets deeper into taking care of that client. What is their med management? How independent are they? How autonomous are they? Are they, are they understanding that their blood pressure, and how well do they take care of their medication management, their blood pressure, their safety in their home? We've identified 144 areas in a home that are unsafe, and how do we take care of that while we're taking care of a client, instead of living in that environment, saying, well, your home's not very safe. You have to fix it. You have to make it better. We have to justify these higher rates. We've had to step up our game considerably. We now have, we're looking at where states allow it, adding nurses. We have to. We can no longer just go the way we were and continue to charge the rates that we have. I think we all have to step up our game.
Right. What about you, David?
Well, I think that, I think the industry as a whole has got to elevate its game in regards to, awareness and outcomes and analytics. You're going to hear from, Bill Dombey, later today. My experience has been, we get restless whenever we get bad news, and then we start trying to reach out for somebody to throw us a lifeline and to help us. And you can't do that. I mean, we are overall a small industry, but there's got to be grassroots efforts in every one of our communities. You need to be having, not only your state representatives, but your local congressmen. You ought to know who they are. You ought to have them go on rides. You should have them go experience what it's like a day in the life of a clinician and the impact you make on patient families' homes. And we need to get more champions out there that understand the value that we bring. And I think the associations, has done a good job. I serve on the NOC board, and we've really spent a lot of time spending energy in Washington and lobbyists and really trying to bring, the value-added benefit, to the surface. But the industry as a whole, when things are good, we're pretty quiet, and we're like crickets. You don't hear anything, and then as soon as bad news comes or rates come, everybody's up in arms and trying to grab a lifeline, and it just can't do that. I think our industry has to elevate up. Everybody in this room, everybody that's a national provider, everybody in the local communities, ought to be wanting to bring awareness to the incredible value add that all of these service lines we're talking about bring, and it's all about having the patient in the right setting at the right time, independently, being in their home environment, decreasing ER visits, decreasing hospitalizations, decreasing facility costs. But there just needs to be a lot more effort, I think, in order to bring it to the forefront.
Yeah, I also participated in the event in Washington, D.C., and I was actually pretty impressed with the number of representatives that we met with that really understood a lot of the issues. So I think we are making progress there.
Yeah.
Right.
Just have to keep working it. Yeah,
Right.
yeah.
Do you have any final thoughts?
Oh, I always have final thoughts. So when I think about just the industry as a whole, I mean, yes, we've got headwinds, all of us in this room, and we could tout off all the things that are those headwinds. And again, I always look at headwinds as opportunity, but we also have some great tailwinds behind us, and that's fueling our growth because there's so much demand out there, and we can continue to touch lives in such a meaningful way. And at the end of the day, that's why we're all in this industry, is because we want to help people live gracefully in their homes and get the support that they need as they go through this process, even if they're children and living with disabilities. How can we support them? But I think, so I am reading a current book called Same as Ever, and it's by Morgan Housel. And what he talks about is many times when you're thinking about what's coming in the future, everybody's like, well, what do you foresee changing over the next 10 years? And he said the right question we should be asking is what's not going to change over the next 10 years? And that's where we should focus, is the things that we know aren't going to change. Because as we think about risk, for the risks that we can anticipate, we think about it and we put plans in place. When I think about AI excites me, and at the same time, it scares me. And so right now, we're in the process of testing some AI functionality. We're dipping our toe in it because it's here to stay. But we're being responsible about that. But there's things that will probably happen that I could never anticipate. Or when you think about, none of us, 4 or 5 years ago, it's probably longer than that now because time flies so fast, anticipated the pandemic, right? So we're always thinking about the risk. We never knew the pandemic was going to come. But when we think about what's going to be the same for the next 10 years, people are going to want to age in the place they call home. That's going to be the place that they choose. Family caregivers are going to continue to feel overly stressed, right? As they're sitting in that likely sandwich generation between taking care of their kids and taking care of their parents. So we're going to need to help them. Caregivers are going to always want to have meaningful employment. And so how can we continue? So if we can focus on those things, which I think is some of what David was saying about the fundamentals, is that's what we need to continue to move forward as we continue to all live out this mission of trying to help people. Yeah.
Mary.
So I think, as well said, Margaret, I think as we look forward, there's going to be, we can't do any of this without one group, and that's the caregivers. And my frustration and my mission has been to elevate the level of respect that we have for the caregiver pool of people that are doing the hardest job out there. It's, the pay, let's be honest, the pay is not great. It's hard work, but you hear people say, well, I'm just a caregiver. Or you hear people talk about their caregiver. It's not a respected field, and it should be one of the most respected fields for what we do. And I think as a system, all of us need to find a way to elevate the level of respect so it becomes a more desirable job. It becomes something that people feel good about what they're doing, not as a job that they have to take because that's what they think this is all they can do. So I'm trying to find that magic potion to make caregiving a more respectable field because, frankly, all these topics we talk about aren't even doable without that group of people. So I think we go forward and in the present, that's what we have to do as a whole
That's
system.
well said. All right, David, take us home.
Well, I mean, listen, I appreciate being here, and I think, the panel's brought up some good ideas. I just think that as we look forward, there's going to be, I think, as I evaluate, I think there's as many tailwinds as there are headwinds, so I look at it on a neutral basis. So I think that organizations have to be as efficient and effective as they can possibly be. I think it starts with hiring the right leadership. You got to have the right leadership, and you got to have the right people that buy into the culture. You then have to understand what the needs of the clinicians are, your care delivery model to try to keep those clinicians, to keep turnover down. That results into better clinical quality outcomes, better patient satisfaction, better margins, better profitability. I think that you're going to have to continue to focus on looking at what the needs of the individual businesses and use technology where it's appropriate to help you maximize where you need to get to. And it's different for different organizations, but there's plenty of technology out there that can help you. And then I think you've got to also figure out how to be innovative. I think you've got to figure out how to do things differently. You just can't be just a standalone home care company or a hospice company or a home health company. You need to be developing clinical care paths and protocols for CHF and COPD and diabetes. You need to be trying to hire clinicians or experts in that. A nurse is not a nurse, is not a nurse, is not a nurse. Find pathways for people to come and work for your organization to where they can do what they've done for 20 years in the hospital and they're experts at that. You'll get better patient outcomes, better quality. And then on the payer side, we're going to have to deal with continued pressure on that. But I do believe instead of, arguing back and forth on a, 10 or 12 or 15% price cut on a Medicare Advantage, you really got to figure out how to go in with quality outcomes and innovation, and you got to sit down and understand what their needs and what they're trying to solve for and convince them that not trying to find the lowest cost provider is what's best, because they could find the lowest cost provider, but their hospitalizations, their ER visits cost, all the things that they're trying to prevent are up, and really show your outcomes and work one off and not just stand back and it is what it is. So it's all about quality. It's all about patient quality care. It's about having the caregivers, and it's about us constantly innovating ourselves to be more recognized as a necessity downstream that really bends the healthcare cost cycle.
All right. Well, thank you all for your insights and observations.
Yeah,
Let's
absolutely.
hear it for